My name is Psutka. I'm a urologic oncologist at the University of Washington in the United States. This is a phase 2 randomized controlled trial. We are looking at patients who have non-metastatic localized muscle-invasive bladder cancer who are planning to undergo a radical cystectomy, and we're randomizing those patients to cetrelimab, which is an IO-based therapy with or without the TAR-200 gemcitabine impregnated pretzel. This is a trial that is specifically looking at patients who are either cisplatin ineligible or cisplatin or unwilling or unable to receive cisplatin. And it's a really important trial because obviously the guidelines right now support the utilization of neoadjuvant chemotherapy prior to radical cystectomy for patients with muscle-invasive disease, but there's many patients who simply cannot receive it. And so we're looking to see if these two treatment options might yield a good response. The outcome of interest that we're seeking is pathologic complete response at the time of radical cystectomy, and that's what we're going to be reporting as the primary outcome of interest for the trial. We will see what the PT0 response rate is. Obviously, with cisplatin, we're seeing rates in the 25 to 30% range. The hope is that we may achieve something similar or higher than that. The interesting feature that we're looking at is whether or not using the gemcitabine impregnated pretzel locally helps us and advances that rate even further. Thus far in the preclinical work, the tolerability of the intravesical TAR-200 agent appears to be satisfactory and tolerable by many patients, including those patients who have substantial other medical comorbidities and you might consider to have a higher threshold or a higher risk for significant toxicity. And with the cetrelimab, the preclinical data suggests relatively similar adverse event rates compared to what's seen with other major AEs, other major IO therapies. We're hoping that this is going to be a trial that a lot of people are going to be excited to jump onto and join us in this effort. At this point, we're planning to randomize 160 patients. We already have 11 patients on trial. It's a trial that's being run both in the United States and throughout Europe and overseas. And I think our hope is that in the next probably 1 to 2 years, we will have the results ready for our readers. I think at this point, the major knowledge gap or the space for which there is a considerable need is we need therapies that we can offer to patients who are unable to receive cisplatin. As we all know, the muscle-invasive bladder cancer patient population have a high burden of comorbidities and in general are older and a high burden of frailty. We need treatments that are tolerable with an acceptable side effect profile that can also yield successful response rates in terms of reducing the burden of disease within the bladder and reducing the likelihood of micrometastatic disease.